About 32 participants. Welcome, everybody. Thanks for joining us.
Fantastic. All right. Well, welcome to the MCSTAP webinar, our monthly webinar. We have an interesting topic today. Today, we're going to be focusing on a case, and then we're going to be translating or seeing how the new guidelines from the CDC on prescribing opioids for pain, how they change or don't change our treatment of patients that have chronic pain. So why don't we get started? So I'm going to lead off by telling we had a lot of attendance, a lot of new people signing up today. So I'm going to take a minute or so to just tell you a little bit about MCSTAP if this is the first time you're logging in. MCSTAP stands for the Massachusetts Consultation Service for the Treatment of Addiction and Pain. And we are, that's our phone number there, 1-800-1833-PAIN-SUD. And there's a website there. And the purpose of MCSTAP is to support primary care teams in increasing their capacity for and comfort in using evidence-based practices in screening for, diagnosing, treating, and managing the care of all patients with chronic pain or substance use disorder. So what MCSTAP is a real-time phone-based consultation service for all clinicians on safe prescribing and managing of patients that have chronic pain or SUD. Basically, if you're using opioids for treatment of pain in your patients, or if opioids are possibly a place that you may be going, we are a group that we can help you with those decision makings. We also have additional information on resources in the community that you can call and request. All consultations from us are free. They're paid for by the state through Medicaid and through state funds, and it's for all patients that are in the state of Massachusetts. So any clinician taking care of patients in Massachusetts can use our service. How can we help? We basically provide real-time help. You call us, we call you right back within 15 minutes, and then we'll tell you what needs to be done, or we'll help you what needs to be done based on the story and based on what the needs of your patients are. So you basically call us. It's almost like talking to a preceptor. You call us, you run the case by us, and you ask what questions you need answers for, and we'll try to help you. Those questions can be around prescribing buprenorphine or naltrexone or long-acting opioids, both in chronic pain as well as in substance use, making changes to these medications or titrating dosing, overall management for some of these cases, which may be very complex. Sometimes changes need to be made, often frequently, and we can provide support in helping changes in dosing and approaches. And then there are other special extenuating issues that come up with patients, special populations, pregnant patients. There's a variety of things that come up. And we're situated in a place to kind of help you with all of those things. We provide personalized real-time coaching. We can do follow-up coaching as well. If you call us, you can call us a year later about the same patient. We still have the records and can kind of help you move forward with the patient. Next slide is, in addition, we have other services. We provide free mentoring services. If you feel like you have a practice that's running out of control around these patients, or you want to get better at it, or if you want to start being able to use the recently approved prescribing of buprenorphine, and you don't need an X waiver. If you haven't heard that, that's relatively recent news. And you have patients that you think could benefit from buprenorphine, but you just haven't started, or you're concerned about how to do it. If you call us, we'll walk you through it. No problem at all. And so we're a very easy way to get up to speed on buprenorphine as well for OUD. So we provide mentoring services, which are in-depth, in addition to phone calls, where you can talk to the same consultant for about 3 months on a weekly basis to run cases by them, to ask questions. Mostly it's case-based. We have outreach to training programs. If you have a residency training program, let us know. And if you want some additional support for your residents, let us know, and we'll see what we can do to help you. And then finally, we have this training that's monthly as well through the webinar. So those are additional services that MCSTAP provides. We have 10 clinicians from across the state. They are all expert in chronic pain and or substance use disorder. They are very experienced teachers and mentoring of providers, other clinicians as well. Many of them have academic backgrounds, but they are all practicing, and they they truly do get what the needs are. And then finally, they have a deep commitment to helping others, especially you guys, because they want their colleagues to do better, and we want their patients to do better as well. So we're really committed to this, and all of my people are here to help you. So today our learning objectives are to understand key management principles to care for a patient living with intractable chronic pain, to gain capacity by addressing the impact of the patient's pain on their quality of life, mental, physical, and social function. So we're trying to improve their lives. We're also going to learn about describing the intent and approach for evidence-based or best practices for implementing the key recommendations from the CDC guidelines, which I've tagged with CDC GPOP 2020, just because it's shorter. And what we're going to do is we're going to go through this case today, and hopefully you're going to learn about the new changes that have been made as we talk about specific management decisions that have to be made in the care of this patient. And overall, we're going to try to describe and help you understand what the impact of these new recommendations will be on the care of patients. Remember, your patients haven't changed, the recommendations have. So these things may impact how you're caring. So let's move forward. This is going to be an open session. You can apply for CME just by sending us an email, but in addition, because we're going to have an open discussion and everybody will be, their mics will be unmuted at some point, it's really important for us to remember that we want to foster a safe, interactive learning environment. And it's critical that we treat each other with respect. Please, when you're listening, keep your video on so that we feel like we're in a group. Please mute your audio and then ask questions in the chat. If you're going to ask questions in the chat, please address everyone. If you want to speak, and remember, you will be able to speak, you can just raise your hand. Everybody is automatically muted, but once you raise your hand and then acknowledge, you can take yourself off mute and you can speak. Please remute yourself when you go off. Remember, no question is unwanted. It's pretty obvious. So let's talk about the CDC guidelines that just came out last year. There is the slides will be available, but the email address to the MMWR is on this link, and it has the entire guidelines in it. So this is a reference point, and we're going to talk a little bit about it. So the CDC clinical practice guidelines for prescribing opioids for pain came out at the end of last year, and it basically came out in two places. So if you go to the CDC directly, if you go to the link on the left, that'll take you directly to the guidelines. If you go to the link on the right, which is suggested by the guidelines at a glance, that can give you kind of a very quick idea of what's going on, so you don't have to dig through it. You may want to click on that at some point after we talk. Maybe you've already talked after our conference today. Maybe you already have. Basically, the content that we're going to cover is going to be in there and will help you. So I recommend that you consider keeping those links handy. So what did they do with these guidelines? What was the purpose, and what's happening with these? So one of the things that was pretty clear with the 2016 guidelines that came out, many years ago, was that there was the use of numbers. There were thresholds that were thrown out there as part of the evidence, and that was totally legitimate. But unfortunately, and as anticipated when it first came out, those numbers became fixed in people's minds. And unfortunately, there was misapplication of those thresholds. So specifically, the guidelines talk about emphasizing general principles rather than specific levels. They, for example, want to avoid increasing doses, avoiding increasing doses above likely levels is likely to yield diminishing returns. In other words, going up on doses may not be helpful, but they're not saying that going on a dose is verboten. If it makes sense clinically and it's appropriate, and the risks and the benefits balance out appropriately, or to your satisfaction, to the satisfaction of the patient, then opioids can make sense. They wanted to be able to provide more specific information about specific disease or pain syndromes to help people with individualizing care. So throughout the guidelines, there are additional recommendations about tips and stuff about how to get the maximal pain management while at the same time minimizing risk to opioids. So it's a more balanced approach. It's not either or, it's how can we use both strategies or all strategies in a kind of appropriate way by maximizing or optimizing synergy and diminishing risky combinations of medications or strategies. There was a lot in the guidelines focusing on equity and equitable access to care and reducing barriers to high quality care. There was a lot of stuff about equity and making good decisions about patients. There was stuff there's stuff in there that talks about being cognizant of unrecognized clinical bias in terms of making decisions about managing pain in various settings. And so there's a general caution to clinicians throughout the guidelines to be much more aware of other extenuating factors that may have something to do with why the person ended up with this with these problems and how to manage these going forward. So they're really looking to kind of stress some of the things that we've learned about in terms of equitable access and racial inequities to apply to managing of chronic pain. We've kind of learned about this over the last several years, and I think it's really wonderful that the CDC has actually interpreted that and realized that the management of chronic pain and substance use disorder involves a much broader thing than just a very narrow focus on medications and behavioral issues. They've added a bunch of guidelines, guiding principles to help with the care around providing appropriate individualized care. Overall, they've written these guidelines to make sure that the right things get done, but also to make this more accessible and more useful to clinicians to actually translate that advice. So they're writing for two audiences. They're writing to improve the quality of care. They're also for patients, but they're also they're trying to train and improve the knowledge base of clinicians that are doing this work. So they have two goals. And again, like I said, they're very, very focused on increasing equitable evidence-based access to pain treatments, judicious initial and ongoing prescribing of opioids. And the point there is that there was a sense that people were not really fully fixated on what the actual pain was and being really clear about what they're treating. Because let's be honest, and we all know this, there are different approaches for different forms of pain. Neuropathic pain does not get treated like musculoskeletal pain. There are different approaches to that. And I think the general understanding was people were just kind of, I guess the way I would frame is people were kind of blinded by opioids. Everybody was focused on opioids and forgetting about the fact that there should be a stepped approach, and that, the use of opioids shouldn't be verboten, but it should be part of a continuum. So that was really what they're trying to do here is that opioids are a legitimate tool to use, but you need to be much more circumspect about how using them. And you need to be less focused on specific thresholds and guidelines and more focused on the context and the clinical factors that are more likely to be impacting on this patient's success with managing your pain. They also gave consideration to other clinical issues, which we're not going to talk about today, but one of them has to do with tapering. Forced tapering became a real issue over the last several years, and there's a lot of work that was done and put into this guideline, reminding people that forced tapers are actually dangerous. There's evidence to prove that, and it should never be done. And so, again, we're not talking about it today, but there is a lot in the guidelines around tapering and how to do that and why it should be done and what the ultimate goals should be. And then talking about how things should be discontinued when necessary. Again, numbers 2 and 3 we will not be talking about today. They gave 12 recommendations. Each recommendation has, they give implementation as well. They gave rationale for the recommendations as well as implementation suggestions. That's actually quite useful. in the previous guidelines, they really didn't talk about how do you actually make this stuff happen. And I would not call this an implementation guide, but these are very good recommendations, some real simple, basic stuff to do that makes sense. And so, once you've kind of gone through the guidelines, you could probably hand these off to your administrators or start a conversation with your operations people about how to implement some of these guidelines. Those guidelines offer, the implementation considered offer practical insights and context and specific examples. Again, nothing is meant to be rigidly followed or inflexible. This is from the guidelines itself. This is the table of contents. There's some preamble stuff, and then on page 17, it starts with the recommendations, 1 through. And there are some, sidebar stuff, but pretty much these are the recommendations. They don't give you titles with them, unfortunately, in this, but I've titled them in terms of their intent as we go through the first 4 or 5 as part of our presentation. Couple more quick things. What's new? They've provided guiding principles for implementing recommendations, I already mentioned. They provided some new data on acute pain and expanded content on prescription opioids. They've provided some really useful new guidance about subacute pain and how to manage it, along with some workflow approaches about, testing out pain medications in that interim period and how you actually would decide whether to continue with the opioids or not. So they provided some new guidance on that. Subacute pain was not really differentiated. It was kind of like acute and chronic, and then just something else. And subacute is like, there's this zone in there where things are moving. It's much more dynamic. And it's not a minor point, because a lot of people that end up on chronic opioids, if the management of their pain in that interim period doesn't really run smoothly or is not clear in people's minds, my sense is that can translate to ongoing chronic use of the opioids and the pain never really moving out of that subacute zone. So I would recommend that area to people. It's an important section to think about. And then, of course, there's a section about health equity and disparities in pain treatment. And there's some impact and some recommendations for mitigation. So when I said that they're serious about this, they have a whole section dedicated to this, and it is not hidden. So they're serious about it, and I think that that's good counsel that we should take that to account. What else has changed? They put a lot of focus on non-opioid therapies, including using a stepwise approach, as well as non-pharmacological therapies are highlighted as well. And the literature and the evidence to back that up are also cited. What's changed? They've adjusted the scope of audience slightly. It's gone more from only primary care clinicians to people that are running into patients in which opioids is sometimes part of the issue. So that includes hospitals at discharge, emergency rooms, other situations, and these guidelines are only for adults. They address both initial and ongoing opioid therapy. They try to clearly delineate recommendations about applying to 2 different classes of patients: initial and then people that are already receiving opioids, because these are really different clinical situations. You have likely an opioid naive individual who's got probably a new or a newly identified chronic issue that has to be addressed. But there's workup, and then there's getting to know the patient. The other type of patient are people that are got chronic pain for many years and have already been kind of impacted by the medical world, and they're different. They're a different substrate, and so really they emphasize in these recommendations to really think about these 2 groups as different types of people. Obviously, people do that already, but patients can be complicated, and very quickly you can start to forget about what are we dealing with here. Also, new pains pop up as well. So it's important to be really deliberate and methodical when you're first starting to approach a patient to manage your pain, and when you get to the point of trying to initiate treatment and whether you're going to get to opioids. They've put a lot into the guidelines focusing on that, which I think is really well placed, because some of the decisions that you have to deal with, you make up front, you have to deal with later on. I'm not going to get into much more of this. Basically, it's just a review of some of the things that basically that they emphasize. Again, they don't want things to be rigid, or they talk about starting and dose increases, and then they provide some other guidance, talking about starting low, making sure that you deal with morphine equivalents as a basis for all medication adjustments or management. If you're not adjusting things, you can make mistakes. And so it's really important to kind of do those conversions up front. Conversion tables are easy to get off online, and a little bit of math and boom, you can add up all your opioids and know what you're really dealing with. I highly advise that because it can be confusing. The guidelines are here to improve this is what the CDC says the guidelines are for improving communication between clinicians and patients, and to empower them to make informed, person-centered decisions related to the pain together. You'll notice it isn't about getting people off of opioids, making people stop having pain, finding people that have addiction. It doesn't say anything like that. This is about helping people. Okay, so it's not a gotcha game. It's intended for primary care physicians and other clinicians that are providing pain care for patients that are outpatients or adult that have these conditions, either acute pain, subacute pain, or chronic pain. Chronic pain is obvious. Subacute pain, it's kind of obvious, and it's fraught because careful decisions have to be made. Acute pain is usually not as hard to deal with, but they're emphasizing that we remember to treat it correctly. I'll give you one anecdote. I had surgery on my knee about 15 years ago. Back then, nobody knew what they were doing. I was given OxyContin, 10 milligrams twice a day for my pain. And, that's not what's done nowadays, obviously. That was a mistake. That shouldn't have been done. We know that now. But my point is that things are changing, and managing acute pain is one of the things that is really important that we get right so that we don't set ourselves up for disaster with patients down the line. All right, this guideline is not a replacement for clinical judgment or individualizing person care. So if you get pushback from the insurance company or blankety blank, the truth is we're doing the right thing. And if they're applying some kind of rule on you, they're misapplying it, and we need to push back. It's not intended to be an inflexible standard of care across patients or populations by healthcare, health systems, pharmacies, third-party payers, governmental jurisdictions, or to lead to rapid tapering or abrupt discontinuation of opioids. That is what this is not. I have taken these words verbatim. This is what the CDC guidelines say. So I'm not interpreting. This is the words. This is not a law, a regulation, or a policy that dictates clinical practice or as a substitute for FDA administration approved labeling. It's not applicable to sickle cell disease, cancer pain, or palliative care end of care pain. And it's not focused on opioids prescribed for opioid use disorder. Okay, the guidelines are not a treatment guideline for treating OUD. I know you didn't do that, but sometimes it's hard opioids, you can start to get confused, especially with this, because when you treat people with full agonists, one of the adverse effects is that they can get addicted. Okay, they can become dependent and eventually develop a use disorder. You have to know about that treatment because you have to deal with that. That's a side effect that it's appropriate for the prescriber to manage. Now, if you don't, that's one thing, but then you still have to refer. So you're going to hear about addiction in these pain prescribing pain recommendations, but that's not the focus of it, which will be pretty obvious when you get in there. You'll see there's nothing about it. All right, so that is our first half of our session. Hopefully I've given you a kind of a broader overview of the general recommendations. Now we're going to go to a case, and I'm going to turn that over to my colleague. I'll switch the slides for you, Jason, but I'm switching up to Jason Worcester.
Hi, everybody. Jason Worcester here. I'm a MCSTAP consultant, so you maybe get me on the phone if you call, but also a primary care physician at Boston Medical Center. We're going to go through a case today, and just in the spirit of thinking about the CDC guidelines as they broke it up into starting, continuing, and discontinuing opioids, we're going to kind of talk about how to take off from the runway today, and not really get into continuing people who've been on opioids nor tapering, just kind of takeoff and using the flight analogy. So next slide, Chris. So before we even get to the case, I just want to bring up some concerns and some ideas for discussion as you think about this case as we present it. And thinking about non-opioid management, thinking about adverse drug effects, events and effects in older patients, especially starting opioids in older patients. The use of non-pharmacologic modalities that Chris had mentioned before. Are there options to use those before, during, or after the use of opioids? How we start opioids, what we need to think about, the risk assessment, the safety concerns that we'll have when we think about starting opioids, how to assess risk, how to coordinate care is important as we think about, because we don't want primary care providers being, the lone person responsible for all their care. It really takes a team, especially in complicated older adults. And then other issues that come up. Obviously, there's always concerns about safety and regulatory aspects of prescribing opioids, but we'll kind of touch on those today. All right, Chris, next slide. So we're going to jump into the case here. So this is a MCSTAP call. So this is a call that came into us, I think, within the last few months. And here it is. So we have a 68-year-old female who presents to her PCP complaining of 6 weeks of new right hip pain. So this is all new. She hasn't had it before. The history and physical done by the PCP thinks that this is probably osteoarthritis of the hip. Orders x-rays. Of course, they're pending at that first visit. And the patient comes in to this visit with this 6 weeks of pains, telling you that the acetaminophen really isn't helping. So the caller calls us and says, what do I do about this? So specifically regarding medications, in terms of kind of what's the best approach to this patient's medications, and what's both the interim pain management strategy as well as kind of the short and long term. Because obviously this is a case evolving in real time. And as we know, we're not going to have all the information. That patient's not going to leave with a diagnosis. So how do we approach it today and in the future, anticipating the likely end result being this patient has chronic hip OA. So what happens is the PCP prescribes NSAIDs, understanding this is a 68-year-old female, and there are risks in doing that. Increases the SSRI dose as well, that and then kind of takes it from there. So next slide. So just another kind of past medical history just to set the context. So again, she's had depression. She's had this hip pain for now just 6 weeks. She's got hypertension. She worked as a homemaker, got a couple kids, and most importantly, has 4 grandkids. So her substance use history, which was taken appropriately by the PCP, never smoked, rare alcohol use, no history of illicit drug use, and no history of prescription drug misuse, nor any history of addiction or use disorders. So a little background on the case. All right, so next slide, Chris. So she comes back 4 weeks later. Again, she was started on an NSAID, and the sertraline was doubled with some hope of helping with chronic pain and or some underlying depression. And the caller, the PCP, asks how she's doing. And she tells you that the NSAID, as well as the doubling of the SSRI dose, really didn't do anything. The x-ray results that were reviewed with the patient shows pretty typical of osteoarthritis, some narrowing of the head, a lot of osteophytes, et cetera, that are pretty consistent with osteoarthritis. And then she's been using a cane to kind of offload that hip, and it helps a little bit. But there's a couple issues that the patient's afraid to go to the hospital due to both anxiety and some transportation issues. And as what we're facing all today is the issues with access. So realistically, she's not going to be able to get into an orthopedist for at least 3 months. So what's going to happen for the next 3 months? All right, next slide. So that's the case. So as we kind of digest the case, I'd like to just go through 5 of the recommendations for the in terms of starting opioids as recommended by the CDC. And jumping to this, because obviously as we go through this case, you can see how this case could develop into starting opioids for this patient, right? Things aren't working, pain is progressing, can't see orthopedists realistic for 3 months, et cetera. So there's a lot of lot of like in the background, is there opioids appropriate for this patient? So in thinking of that clinical decision making, let's go through what the CDC says. Okay, so the CDC tells us to use non-opioid therapies initially. And this makes sense. We've done some of that with this patient, SSRIs, using a cane, using some NSAIDs. And really the goal is to maximize the non-pharmacologic and non-opioid therapies as well. And I think many times patients are obviously looking for the quick fix, like give you a pill that's going to make this all go away. But really using a multimodal, multidisciplinary approach to chronic pain is really important. Next slide.
Jason, before
Yeah,
we
sure.
we jump, I guess there was a comment that I wanted to make, which was, it was a question, which was, when I have seen this situation as well. A person comes in, I'm trying to figure out what the pain is. I'm giving them something for the pain. And they say they're taking Tylenol or a non-steroidal, and I give them medicines, or they've been taking it already on their own. And I can't tell you how often when I ask them about the medicines, they haven't been actually even taking the medicines correctly. They've been taking 200 of Aleve once every other day. And so it's really important not to interpret that they say that they've been taking these medications, because they probably haven't been taking them the way that you would want them to. So I always kind of revisit the non-opioid medications to make sure that people are actually taking them seriously and taking them as prescribed. And that often really makes a big difference. So just a little pointer there.
Yeah, and the other kind of similar to that thought process is many times people have tried things in the past that didn't work, and that doesn't necessarily mean it's not going to work now. So sometimes people dismiss kind of other modalities or therapies as well. So it doesn't hurt to kind of revisit both. Are they
Right.
really
Plus, there's also this urban myth that, opioids are always the strongest. So they often just discount, well, Motrin won't work. Everybody says that, and they don't even try it. So I think it's really important to be intentional about that and explain it to patients that, no, I really mean this. Because if you use it correctly, it may actually do something. So
Right, exactly. Okay, so going on to the second recommendation from the CDC and thinking about initiating opioid therapy. So next slide. So here again, non-opioid therapies are preferred, and really the goal is to maximize these therapies, really to use them as much as you can. And to really, the other key point is to when you're discussing with patients is not so much necessarily pain levels, rather thinking about functional status and other concrete, tangible things that patients can latch onto that it's actually improving. There's formal scales we can use, like PEG scales and things like that, or just asking people, are you able to walk more? Are you able to work, do more with your 4 grandkids? Things like that give some kind of functional improvement. And then, and as we're going down the path here of considering opioid therapy, it's important to both have a risk-benefit discussion, but also I think it's important to come up with, like, what's the plan here? Are we, is this just a trial to get you to orthopedics? Is this till you get your hip replaced down the line? Like, what's the short and long-term therapy plan here? So we don't get into that subacute pain limbo period where it's unclear, gray, and murky, and then ultimately just end up in like someone on chronic opioids that may not be appropriate for. So really establishing a concrete treatment plan to give that patient expectations, and then going over the risks and benefits of opioids as well. Next slide.
Jason,
Yeah.
Jason, we have a question in the chat,
Sure.
and I'm going to read that in a second. But I'd also say to people, please, if you have questions, you're all able to ask. So either put them in the chat, or please just come off mute and feel free to interrupt, because we want this to be interactive. The last time we did this, we did get a lot of questions, and nobody was humiliated. So don't be afraid. If you have questions, please just raise your hand and let us know. The question here is from Judith Odenheimer, and is, can you address the use of COX-2 inhibitors for step-up therapy from OTC NSAIDs?
Right. So reasonable to try, right? I mean, the one thing we heard here is that we tried naproxen, which probably has a little bit lower GI side effect risk profile. They all probably have similar kind of renal of course, we didn't present her creatinine or any GI bleeding history, but just in terms of thinking of a 68-year-old stomach and kidneys, as well as now heart, as we think about issues with NSAIDs and heart disease. So I think it's an option, trying other NSAIDs. People may get benefit from a different NSAID, including the COX-2 inhibitors. So I think it's definitely, little trial and error, I think is reasonable to do.
Yeah.
Again, looking at side effects and, as to whether it'll work or not, you don't know until you try, but it could be an option if that patient is willing.
Jim, any thoughts about this? What I can tell you is
I am on mute.
Oh, go ahead.
Sorry.
Go ahead.
Sorry about that. I fully agree with Jason. We need to look at the risks of the NSAIDs, and certainly the COX-2 is another option. A comment that came in the chat from Sarah Lennox mentioned, what about other therapies like topicals, CBD? What about the topical NSAIDs and even physical therapy for people with joint disease before we jump into opioid therapy? All of these non-pharmacological options should be considered for our patients. In the end, we're facing decisions about if and how to initiate an opioid when the pain is so severe that it interferes with daily life.
Yeah. One of the things about the COX-2 inhibitors I just wanted to mention before we keep going is that all of the clinical relative and absolute contraindications notwithstanding, one of the advantages of the COX-2s is the fact that they're once a day. And I find that, one of the challenges with non-steroidals is that they're multi-day. Most of them are multiple per day. And that's just a challenge in general. The nice thing about the COX-2s is they're often once a day. There are once a day NSAIDs out there that are old NSAIDs that still have all the side effect issues that come with the old NSAIDs, but they are once a day and people generally don't use them because I don't think they know about them. For example, piroxicam is a once a day NSAID. Voltaren is a once a day NSAID or can be used as one. So there are once a days out there that will actually do it. Naproxen, taken at a high dose in the morning, sometimes for some people will actually last the whole day, although it is a BID drug. So, that's one of the reasons why people think about Celebrex, not just because of or things like COX-2s, not just because they may have GI protective, but on top of that, that they're more long acting as well. And my point of this is that there are other ways to get long acting non-steroidals if you want to. We have another question, and somebody pointing out about hypertension and NSAIDs, and that's absolutely an important consideration that the NSAIDs need to be considered when renal function is possibly an issue. So the statement in the comment is that it's not uncommon for people to miss it. And so, yeah, I agree. It's important. If you're going to be thinking about NSAIDs, you need to be making sure that you're monitoring renal function before and after as well. Okay, I think those are the questions at the moment. Again, please keep them coming in. It's more important that we make this interactive. Okay, next slide, I think.
Next slide, yeah, sounds good.
Okay.
Okay, so the third recommendation from the CDC in terms of kind of taking off your airplane here is when determining if one is going down the pathway of using opioids. Again, it may or may not be appropriate for this patient. We can discuss that later, but use short-acting opioids. Do not start with long-acting opioids, and that may seem obvious, but obviously with Chris's knee surgery example 15 years ago, it does happen, and but typically start with short-acting opioids just because of the safety issues regarding that primarily. Next slide, Rec 4. Okay, and then when considering the dosing, you want to account for other risk factors. Okay, so things to think about would be that particular individual. What's their kidney function? What's their liver function? Are they at risk for falling? Do they have some underlying mild cognitive impairment? Are there drug-drug interactions to think about? And also kind of important would, again, thinking about this, and these are the kind of things that you think about clinically, but also should fall into the risk benefit discussion, informed consent discussion you're having with your patient. So they understand what you're thinking about and all the implications of potentially starting opioids in a patient. Okay, recommendation 5. This is our final recommendation that the CDC put out regarding starting opioids. And again, weighing risk and benefits is important. And then, in terms of like, once you start, continuing opioids, even in the short term, again, reassessing over time, continuing to maximize non-opioid modalities, thinking about obviously the physical therapy, corticosteroid injections when appropriate, all those things that are important in terms of managing chronic pain, and not to give up on those. You continue with those, and also to have a kind of a short-term plan in starting opioids. I like to think of starting opioids as almost like a trial. If they don't work, you don't necessarily have to continue them, and letting patients know that ahead of time, not necessarily getting into this pattern of just escalating doses that aren't actually effective over time.
I think it's important to, when you have that conversation, it's very easy to have that conversation before you even prescribe. So it's really important to do that, because when you have that conversation up front, you can approach it totally from the perspective, I'm doing this to keep you safe. And it makes total sense, and it feels right, and it feels comfortable for the clinician to say that. It doesn't feel like a risky thing. It doesn't feel like, I'm protecting myself or we're trying to hedge a bet. It basically allows you to just have the conversation with the patient and talk about the facts. And when you do that in a non-passionate way, you're actually modeling that to the patient, and you're saying, this is part of regular care. This is routine. This is what we do to keep you safe. And it doesn't lend itself to people feeling like they're being watched, they're not being trusted, that somehow they're being stigmatized, or that somehow they're not being told the truth. And that's really important. And so when you talk about setting expectations with people, especially around monitoring, it's a wonderful opportunity to practice and to also set expectations about what kind of communication you'd like to have with your patient and how you do things. So it sounds like it's a minor thing, but it's actually really, really critical to establishing the relationship going forward. And I recommend that people really pay attention to discussing how you'll be monitoring them over time. Because really what you're doing is you're defining your relationship with them over time. And if you start doing things that they're not expecting, or that they're uncomfortable with, and you don't realize it, you're going to have troubles. You're going to have problems. So anyway, roll to the next slide.
Next slide, Chris. Thanks.
Sure.
Okay, and this is just a continuation of recommendation 5. Again, optimizing other therapies, and if warranted, to stop and or taper if things aren't going well after initially starting medications. There's no necessary commitment that one has to continue opioids indefinitely if the risk benefit ratio isn't there. But of course, in tapering opioids, you want to make sure it's done safely. And we're not going to talk about tapering today, but there is a lot to tapering. But I guess centering around safe engagement and safety is critical when you're tapering opioids in patients, even done in the short term.
Jason, I'll just pop in. One other thought about assessing risk longitudinally is getting used to and anticipating the risks will change over time. It's a little bit of a fantasy to feel like we can just have this conversation once and everything will be sorted out and we'll all be on the same page at the initiation. But it's not the way it works. People's minds wander and situations change and stuff. So it's very, very important that you continue to keep this attitude going over time with the patient and make it more of a dialogue, so that it doesn't become kind of like one day you've had it and, or you're too scared and we have to stop, like a decision get made today. A better way to do it is to say, listen, I'm starting to see activity that doesn't make sense or is not safe, is worrying me, you had an early refill 3 months ago, or, you know, you forgot to do the urine or whatever, something's not working right. Kind of reminding people that this is an aberrant behavior, and it suggests that there might be chaos. We need to make sure that things don't get out of control. Otherwise, I may not be able to continue to give you this medicine because I'm be afraid it's not safe. And so that's the kind of conversation you can have with people without necessarily saying it's time to taper, you know, and have this, like, you know, down and dirty discussion that's very stressful. If you kind of have that conversation in small pieces, as things, if you're paying attention as these things are starting to slip in one direction or other, you want to nip it in the bud. So I won't belabor that any longer, but I think it's important that you take a kind of a longitudinal approach and keep an open dialogue as you're doing that ongoing management. So, Jim, do you have any thoughts?
Absolutely. We might as well look at that reminder of what we want to discuss about with this patient.
Okay.
The next slide will bring up a reminder of what that is. Right? One more?
I think this is it. So
Okay.
decision is, so the current status is, so go ahead.
We've got a patient who's in substantial pain. She's tried. We're going to presume we've had a good, adequate dose of NSAIDs plus acetaminophen plus offloading that joint. Using them appropriately, but they're insufficiently effective, and her functional status has deteriorated, and she can't be scheduled for surgery right away. It's going to be 3 to 6 months down the road. She needs a new pain management plan. What do we need to do right now? Assess her current regimen. We've done that. We've added NSAIDs, we've offloaded the hip, and we're considering adding an opioid. Let's look at the risk-benefit analysis, and then we want to make sure we're coordinating with the surgical team as we talk about her short and long-term management plan. How are we going to, if we're going to use an opioid, make sure it's clear that we're going to plan to treat her acute, subacute pain in that hip with that drug, and then be expecting to taper off of that medicine as her pain improves post-surgically. If we go back and look at those key clinical concerns, we've talked about non-opioids. We have to think about the adverse drug events, and I'm glad it was raised in the chat about, well, what about hypertension and NSAIDs, and isn't this patient going to be at increased risk for renal insufficiency or even cardiac events, not to mention the gastritis and bleeding that we talked about. And I have plenty of patients whose creatinine's up at 1.8. I don't really want to put them on a full dose of naproxen, and I'm sure you don't either. What will we turn to? We may be in a situation where an opioid analgesic is the best option for that person when other non-drug therapies are not available to us.
Yeah. Jim,
so let's talk about how we might start an opioid.
Okay, Jim, and there's a question in the chat which connects to that, which is, it has to do with how do you make the decision we're about to make now with respect to whether the patient is opioid naive or not. So maybe just add that into the calculation.
How do we make a decision that the patient is opioid naive?
Well, I mean, we're deciding whether they should have opioids or not. Whether we want to add opioids, and then the question is, you know, how do you adjust if the person is not opioid naive versus if they are?
Well, I assume we're talking about the person who's non-opioid naive is somebody who's been taking opioids on a regular basis already.
Perhaps.
If they had an acute problem 6 months ago and they were on opioids for an extended time, but they've weaned off, we may anticipate that we might be, I wouldn't necessarily start them at the dose that they were tolerant to 6 months ago if they've been off the drug for a while. But I would expect that my 5 milligrams of hydrocodone with acetaminophen may not be adequate for that person who will have a tolerance that will clearly be making that dose inadequate for them. But that means we give a trial dose and reassess. It may require a phone call to the patient or from the patient 48 hours after they start taking the medication. One nice thing about these short-acting opioids is they work immediately. You don't have to build up an accumulated dose. We want to avoid that. So we can get immediate feedback about the effect of the medication and make a plan to adjust the dose.
Yeah, I think that's, I think the key point here is that the challenges here is that this kind of care, especially when you're adjusting doses, it's really high touch. You need to communicate, and you can't say I'll see you in 6 months or 3 months or even a month. You have to like either build a system, have your nurse check, you check, have the patient call you or send an email in through Epic or something. But unless you have some kind of feedback mechanism, it's really hard.
Naive or not, we have to remember we now have a regulation before us with the state of Massachusetts. We won't write an initial opioid prescription for anything more than 7 days. And certainly for most cases of very acute pain, that prescription might be only for 1, 2, or 3 days. And we find that most people don't take more than 1 day's worth of medication when we prescribe them. This is a different situation of a severe persistent pain that we can expect. We might write that 7-day prescription.
There is another question that popped in. I know you're not done with this case yet, but with this review, but there's another question that came in around medicine. So there was somebody asking whether there's a role for gabapentin in this type of case. I have my own opinion, but I'll let you take a first crack.
My first crack is it certainly has been shown effective in some acute pain management and has been used in some postoperative pain situations. I find that getting an adequate dose of gabapentin in an ambulatory patient requires a prolonged titration of dose without having a very sedated patient who's likely to fall down. So I don't tend to use gabapentin in this type of situation.
Right, yeah. Also, my sense is that I really reserve for gabapentin for neuropathic pain. I think that's dicey utility even in that situation, but that's about all I want to use it for. I find that most of my patients that want gabapentin, and this is only my opinion, I think they're looking to get their mood stabilized. They just want to calm down. They want to, they just don't want to have too much stress, and it kind of calms them down. And that's why they like it, but I don't know.
Yeah.
It certainly raises the risk of overdose with opioids, especially in other individuals that may have other substance use issues. The addition of gabapentin it makes you it's not a sedative, but it has a sedative side effect, and it's been implicated in overdosing. So I don't really feel that it's appropriate medication for this situation, and it's even dicey even when there is an indication because of its other side effects.
And when we're going to talk about prescribing sedating meds like gabapentin or an opioid, we have to remember we have to have a conversation about driving and assessing your tolerance to this medicine and alertness for 48 hours before you drive after starting meds like this. Likewise, we've got a patient with an unstable hip, walking with a cane now because of her pain. She may be more prone to falls, and these medications increase that risk, and guidance about safety will have to be provided while we're talking about safely taking the medication as well.
Does anybody in the audience have a strong opinion one way or the other of starting or not starting opioids? What would people do?
Let's see, we have somebody in the chat. What about, let's see, what about the physical therapy and exercise? Even if the joint must be offloaded, a patient can help with pain. It can help with, PT can help with pain dramatically. I totally agree with that.
Mm-hmm.
See if
we didn't call out the specific kind of non-opioid modalities, but yeah, there's a whole number of them. Some of them can be effective, some of them, well, it's kind of individualized, but definitely trying different things, I think is reasonable. So
okay, we're just about to the end here. We got 4 minutes left. This is, I can leave this slide up here, but we can bring this back here and just open up discussion even broader in general, not necessarily about the recommendations, but general questions about how to do this or other specifics.
I think one of the important questions about introducing, if we're going to introduce an opioid for this patient, we've decided the risk is reasonable compared to the benefits this patient may get. What are we looking for her to be up and active, whether it's being able to get into work, do some functional activity around her home, spend some time if she's retired, supervising grandkids or whatever it might be. What are we trying to achieve? Use the medication just for that and not necessarily, and encourage her not to be planning to take this medicine around the clock and use it sparingly for the activity she really needs it. And otherwise continue the non-opioid pain management for the general ache that comes when she's simply seated on the sofa. I often tell patients, my goal is not to help you sleep better on the sofa all day, but it's if this medicine isn't helping you get up and be more actively engaged in your life and your work or your family, then we're probably not having benefit that exceeds the risk of using the opioid.
Right. A nice catchphrase that I learned from Dan Alford many years ago, which I really like, is that you don't want to terminate your patient, you want to terminate the treatment and come up with a better treatment. So we have 2 minutes left. We still have 59 people on the call. I think we have a couple more questions just popped up. All right, so here's one from Frederick Baker. I'll negotiate with patients when starting opioids. Try to reserve at bedtime to facilitate sleep, and patients seem accepting of that. So that's one comment. Another comment from Claudia Koppelman is most patients do not want opioids, in my opinion, but those that do, I always say the opioids will not get rid of all the pain, but will lower the pain to a tolerable level of discomfort to live. So, again, what you heard in those things is, trying to get people to figure out good ways to incorporate into your life that doesn't, that the side effects from opioids don't create real problems. And the other one is just being open about it and realizing that setting expectations and realizing that our goals are not necessarily to make you pain-free and good looking, just, able to get through life.
Yeah.
And as good looking as the rest of the people.
And just one quick comment on, actually, if the decision is made through a risk-benefit informed consent discussion and you assess functional status, you've kind of gone through thinking about all the recommendations that the CDC has given us, but also kind of clinically makes sense that I think we probably haven't really wouldn't necessarily kind of disagree with any of them, nor probably most have not been doing much different than, over the last few years without these specific guidelines. I think, practically starting opioids in a patient like this, if you were to go down that route, you'd be using very low dose oxycodone or hydrocodone, a short course just as a trial, and having that person do it, especially as someone 68 with some other issues, doing it in a very controlled setting, making sure they're safe at home taking it, and just kind of seeing how things go. I think so. It's these very low doses to start, just as a trial, and see, if you were to go down that route.
There was one more comment from Claudia Koppelman, and the comment was, and to make sure that they sign their opioid use contract. And what I would say, I would agree with that, but I would like to qualify that. It's not so much about the signing, because we're not trying to catch people. What we're trying to do with contracts is we're trying to use that as a tool or an invitation to have an informed conversation about why are we doing this, and and how are we going to manage it to keep you safe. And when things don't go right, how will we deal with it? That's what the patient-provider agreement is. I choose not to use the word contract specifically because it's not a contract. It has no standing in the law. It's not enforceable. And the truth is, you can't make anybody do anything. So it's not really a contract. What it is it's a tool to set up a conversation and to report and to record a couple of things that we agree on, so that we can review them in the future to say, oh yeah, we did discuss this.
Yeah.
So contracts are really, I think it's really important to kind of not give them any more power than they have. I think when they're used as a guide, they're very, very useful.
Yeah.
Jim, I think
our
you were gonna say something?
institution, I'm sorry, Chris. At our institution, we call it the controlled substance agreement for that very reason. And if somebody's dependent on opioids for their chronic pain, and you decided we need to pull out this agreement form, if they don't get the medicine from you and you don't, and they don't agree to sign that form, they're going to go in withdrawal, be very sick, and be at risk. So it would be a coerced signature at best on the contract.
Right.
So we won't call it a contract. We got our attorneys to drop that word very quickly for us. I want to follow up on Fred Baker's comment about sleep. I mentioned I don't want people to sleep on the sofa all day, but getting sleep is very important to cope with the pain during the next day. And if that pain when you lay down is so severe that you can't get rest, it does make sense that might be a time that they use medication, and then they better cope the following day. That's a very reasonable approach, Fred.
Fred also had another thought. He put out the word tramadol could be a nice way to start. And I think it ties in to the contract, to the agreements, because this all should be done, or most of this should be done, when people are in that subacute range. I mean, ideally, when people are in that subacute pain zone, and they're starting, and the doctor and the patient are starting to realize that this may be a chronic issue, and that that the use of opioids may become a chronic concern. It's really important. This is the time when the contract should be done, because, or just after this, because, you know, you're thinking about, oh, this may be a long-term thing. How are we going to approach this? We need to start thinking about this. You don't want to have somebody on long-term opioids for 3 months before you pull out the contract. You want to do it, you want to put the contract, the agreement, you won't pull it out now. And then this ties into tramadol, because sometimes I find that people use these lower activity or considered low potency narcotics or opioids, thinking that somehow they're going to hedge a bet, and it's, you know, they're not going to affect anybody, not there, you know. But I also worry about those meds, in that people might think, well, what's the big deal? You know, it's just it's just a very impotent opioid. It's not dangerous, like codeine. You can't get into trouble with this. And the point is, you can. So it's important to think about, you know, where you think, what's your mindset here, and what you should be thinking about in the next couple of months, because you don't know, you might escalate. And the last thing about tramadol is it's not a pure opioid. It has SSRI effects. So the patient might be getting a little bit better because of the SSRI effects, but you're interpreting it, and they're interpreting it because of pain medicine, because of pain relief, and that may not be the issue. So you have to be careful with tramadol, I think, because you're not getting a pure effect.
This patient's already on an SSRI, so we always have to be aware of the risk of serotonin
Right, of course.
syndrome.
If you added tramadol to that, yes.
Fortunately, we're talking about low doses of both right now, but yes, that's still a consideration.
No, that's a good point. Anyway,
Well past our time, and we still have a lot of people online. If anyone has questions, I think we could reasonably continue to answer some questions, but I think we should thank all of you for your participation in this afternoon's webinar.
I would agree. Thank you all. We'll be here next month. We're going to take this conversation to the next set of guidelines. We're going to start with guideline 6, and I think we'll take that through until like 9 or 10. It'll be around monitoring and ongoing treatment of patients with chronic pain. So we'll see you in a month. And
I should say, I'm on call for the next few hours, so if you have additional questions, just call into the line.
Okay, good. And there was a question about CME. Let's see, if you email Emily Johnson, or you go to the MCSTAP website and just put in there, she can give you some instructions about how to get CME.
I believe she'll sends an automatic email out to every participant who's registered for the program.
Oh, that's right. That's right. That's right.
If you happen to be listening in with a colleague and you did not register, then send Emily that email.
Great. All right. Well, thank you all. We'll see you in a month. Thank you very much.
Thank you so much. Excellent.
Bye-bye.
Bye, everyone.
Bye, guys.
Bye-bye.
All right.
Thank you, everyone.